Health Minister Nicola Roxon yesterday made it clear why the government wasn't funding a dental scheme. At $4 billion per year, it simply wasn't financially possible at this stage. But the answer on mental health is less clear. In a moment, we'll be joined by Professor Ian Hickey from the National Advisory Council on Mental Health. But first, the Health Minister Nicola Roxon joins us. Minister, good morning.
Good morning.
Let's deal first with some of the elements in this health budget that we haven't heard of. Medicare Locals made an appearance. What are Medicare Locals? What will they do?
Medicare Locals are going to do what the local hospital networks are providing for hospitals, and will actually mean that in your local area, local GPs, pharmacists, physiotherapists, mental health nurses and others can all actually work together to provide services for a local region. What we've got at the moment is thousands of individual primary healthcare providers in many communities, not necessarily connected with each other, not necessarily able to work and talk around a patient. The Medicare Locals are really a way to start people organising across those professional boundaries to get better care for patients.
But they won't be practices, like giant practices.
No, what there'll be is actually primarily support for all of the health professionals, but they will also provide a gateway to health services between the hospital and the GP. Think, for example, if you are in hospital, you live in a certain area, you've never been to a GP, there's a large number of Australians who don't have a regular GP, you need to be discharged, the hospital doesn't have anyone they can contact. They'll now be able to call the Medicare Local and say, this person is in your area, needs a GP, can you make sure that they have a GP so that they are not discharged without any support? And the Medicare Local will have the job to go and find a GP. They'll have roster systems, they'll work together to be able to make sure people aren't falling through the gaps. And that's one of the big things we're trying to deliver with this health reform.
Some doctors fear that it might end up being an entity that ends up competing with existing GP services.
No, it's not going to be providing services. It's going to be working to support professional primary care providers and also to encourage them to work together more.
Well, talking about GPs, you've promised another 23 GP super clinics, and we talked to the Treasurer about this yesterday. Really, how can the public believe you when you say we're going to build another 23? You told them you were going to build 36. You said we're going to build 36 super clinics. So far, only 3 have been built. Another 11 are underway. What's suddenly going to speed this up?
Well, what we committed at the election was to 31. We have it's a 5-year program. We have 11 of those already providing services. We have 20 that are in total that are under construction. This is actually a good program which is working extremely well. And you go and talk to people in each of those communities, they understand the value. For example, I turned the sod at Redcliffe Super Clinic. It's not yet operating, it's just about to start being built, but they are going to be training 20 health professionals, doctors in particular, in the Redcliffe region. They have never trained doctors as GPs in that region ever before. And they can see these big changes. If it takes another 6 months for that to be built, they're fine.
So in how many years will we get the 31, was it, I beg your pardon, originally promised, and this 23?
Yeah, 31 for the election. We've added another 5. This 23 will be rolled out over the next 4 years from the election, so we're not promising that they will start tomorrow. Another important part of the program, though, that we announced in the budget is smaller grants available for existing GPs, and they will be able to come online more quickly.
And these are grants for building, a bit like the school buildings program?
Yeah, they're infrastructure grants so that doctors can provide, for example, more team support. They might be able to employ an extra practice nurse or a dietitian or a visiting specialist, or they might provide more services to the community, and they can get infrastructure grants if they're going to expand their services.
Oh, but it's not for capital works?
It is all for capital works, yes.
Okay. Another promise to help with primary care, local care, is going to your doctors, is to ease some of the pressures on doctors, providing a lot of money to subsidise GPs to employ what's called practice nurses. Nearly 5,000, something less than that, but up to close to 5,000 more practice nurses. Where are these nurses going to come from? Isn't there a nurse shortage in this country?
There is a nurse shortage, and one of the problems we have is retaining people who are trained as nurses in the health system. There's about 100,000 nurses that are qualified that don't currently work in nursing at all. And what we understand is that at different points in people's lives, some nurses won't want to work shift work in hospitals. Many will and always do. This is good employment where the community needs nurses, where they can often work part-time, they can often work school hours, and they're dealing with the growing numbers of people with chronic disease. So we're hoping to attract some of those people and keep them in the system. But of course, we are also training more nurses. We've got more than 1,000 new students in nursing, extra university places services that have been introduced since we were elected, that of course means we're also trying to meet that demand by training more nurses.
I'm just wondering though, if you're in the realm here of, again, over-promising and under-delivering, because there's not those nurses to go to practices now, are there?
Well, there's not those nurses instantly in the system. I don't think so. We've worked very closely with the professions, both the doctors and nurses. We had a program which was not as successful as we had hoped in trying to bring nurses back into hospitals. We've now said that program, we understand it hasn't been as successful as we hoped. We've worked very closely with the professions to make sure we're making an investment in an area where it's most needed. So we do have more confidence that this program will be successful.
Okay, more than $7 billion thrown at health in the budget, but not much for mental health. Yet the government claims the Commonwealth will take is taking full responsibility for mental health services in the community. How can you be making that promise when you're offering less than $200 million extra for mental health? Why is mental health the poor cousin here?
Well, I don't think mental health is the poor cousin. Of course, you've got to look at what we're making extra investments in and of the significant investments we're already making. We are doubling the amount of money that's being spent in mental health over the coming 4 years to what has been spent in the past 4 years. That's just growth in the existing services that we provide, programs as well as the Medicare item numbers, which are growing exponentially. The additional announcements as part of this reform were just under $200 million, more money for Headspace, these youth services where we know there are big gaps, and trying to reconfigure the way we provide services within the community. Not the specialised end of mental health services, but the front end of community mental health. And that's a big change.
There's a recognition, I think, that the government is putting the money in the right places, but not nearly enough. For instance, Patrick McGorry, psychiatrist, Australian of the Year, says that the money you've put in, the extra $20 million a year for the 30 new youth-friendly mental health services, will only shave 3% off the waiting list of 750,000 Australians needing these services. These are life and death services.
They are, but I think that people do understand that you have to grow within your capacity. There are currently 30 Headspace services. That's taken 10 years for them to be properly established.
But why not a mega effort? If you can put all that money into building extra rooms on doctors' practices, wouldn't it be better to putting more effort into community crisis teams and community support for mental health, which, as I say, life and death?
Yeah, we are doubling the number of those services. That is a quick expansion for an organisation that has not been up and running for a long time. We have to be able to properly staff them. I think it's a big extra investment. I totally understand why Professor McGorry would like even more money to go into these programs, but it isn't possible for us to do everything at once, and it's not possible for the system to absorb everything being done at once.
Are you saying that's the issue here, the system catching up? It's rather than the budget restraints, because there is a lot of money for health and, as I say, less than $200 million new money for mental health. Is it more about your assessment and presumably the department's assessment about whether the services, the pace at which they are equipped to move?
It's both. It certainly is both. Of course, we have to still keep within financial constraints. We've been very successful at being able to get investments into the system, but we have made a decision that we need to build the foundations first. And there is a lot in mental health in money that we already spend that is not yet properly in order. And I think the mental health professionals all agree with that. And we need to be able to get our house further in order. We need to be able to improve the relationships with the states and territories, and we've got the first agreement to do that in community mental health. And then, of course, we'll be looking to expand services further. But I'm very confident that this is a good budget for mental health. It sets the right groundwork, if you like, or lays the foundations for further reforms. But we've got to understand how much change is possible within a period of time and make sure we can deliver on it.
Do you have a timeline in mind, a target timeline in mind for that expansion? Mental health?
We certainly do. We've agreed with the states and territories that we will come back to COAG probably by the end of 2011. We've said 2011 as early as possible, but I think realistically it will take us a good 12 months. In the meantime, we're rolling out these other investments, and I'm very confident that the primary care structures, the Medicare Locals we talked about to start with, provide us with a whole lot of local organisational opportunities which will help coordinate mental health care better for people living in the community.
Nicola Roxon, thanks very much for joining us.
Thanks.